Good afternoon, everybody. For those of you who I haven't met yet, my name's Rich Sates. I'm the chair of the Department of Community Health Sciences. And it's a great pleasure for me to introduce to you Jody Rich. I got to spend some nice time on Cape Cod running with Jody. It was last year or maybe 2 years ago as we were training some docs in addiction medicine. And what I learned from that was that he's a really nice guy and a good guy to spend some time with. But today I'm looking forward to learning some things about incarceration, HIV, and overdose. Jody is a professor of medicine and epidemiology, although his appointment shifted from, I should mention, community health, which is, community health sciences, right? So from community health to epi, it wasn't a purposeful thing on his part, so it's not his fault. It's that that at Brown they became a school of public health, and then the appointments changed because of the structure. So he's a professor of medicine and epidemiology at the Warren Alpert Medical School at Brown, as well as the School of Public Health there. And he's co-founder and director of the Center for Prisoner Health and Human Rights. He got his MD at UMass, then did a residency at Emory, another good public health place, got his MPH from Harvard School of Public Health, and then did an HIV/AIDS fellowship at Brigham and Women's Hospital. He's got the usual CV for someone who's successful. So he's got 150 peer-reviewed publications, hundreds of indicted talks, regional, national, and international, a NIDA, a K-24 from the National Institute on Drug Abuse, and a long list of mentees to go along with that. 27 grants list. I didn't know you could get that many grants in a career because you have to start early to get 27 grants. And as I said before, he's a really good guy. So let me turn this over to Jody. Thanks for coming up from Brown.
Thanks, Rich. Now, he has a lofty position here. I don't want to, throw too much water on it. Some of the things he said might not be that accurate. Or, it's true, I might have been a nice guy 20 years ago, but I've been behind bars every week for the last 20 years. And some people think that's remarkable. It's actually more remarkable that I've been released from behind bars every week for the last 20 years. The first time I went into prison, I was trained as an infectious disease doctor, going to see some patients, and I walked into medium security and these razor wire, chain link fence with the razor wire on the top, 14 feet high, and it was kind of intimidating. And these doors that close, chung chung, just like the TV show. And I go through one and buzzed in and go through another, and then they say finally, "Okay, Doc, here, you sit here, and we're going to bring the inmates to you." They don't call them people; they call them inmates, or the offenders. And so I sit there and I'm waiting, and there's a stack of charts, and I'm at the desk, and they're going to bring the inmates to me. And I look, and this is my very first clinic, and I see there's a red button here. And I look closer, and it says panic on it. And I'm starting to think, uh-oh, what have I got myself into? And then I look a little closer, and actually it was one of these little square buttons that you just peel off and stick on. It wasn't connected to anything. I said, okay, I think I can handle this. So I'm going to talk about incarceration and HIV and overdose, and I'm actually going to start with overdose. I probably have too many slides, so I'm going to try and go a little fast at points. I should disclose I'm a stockholder in Hermes, which might come up. This is going to start at the medical examiner's office. Our new director of health, who's been there in Rhode Island, has been there for about 2 or 3 years. His first day of work, he went across the street to the medical examiner's office, and as Monday morning, as he's done every Monday morning since, and there was 4 bodies laid out, all who've died of an overdose. 4 bodies on a Monday morning, 4 a week. And ever since then, he's been going there, and there's been another 4 bodies, and every week that's been about a steady drumbeat. So he made this one of his priority areas, just a few handful priority areas, that this is something we really need to do something about. This is the Rhode Island. Now, Rhode Island is a population of about 1 million, so He started right around here. So let's see, this is 2011, maybe, between 150 and 200. It's gone up, and then this year it's spiked up even more. If we look at this is prescription overdoses, the same time period. So just prescription, and you see that these are prescription alone, these are prescriptions with alcohol, and these are prescriptions with illicit drug use, and these are all three. And this is up to, 130. It's not, and so the previous slide we had about 150 or so. So the majority of these overdose deaths are involving prescription opiates, with or without other substances. And we know adding other sedatives can increase the risk of fatal overdose. This is I'm going to make the point over the next few slides that this overdose epidemic is related to prescription opiates, in case I haven't made that already. 2.6 million people taking prescription medicines for non-medical purposes. And emergency department visits have increased, and prescriptions through emergency rooms have increased over time, as you can see. This is in 2005. Overdose deaths in these states, including Rhode Island and Massachusetts, outnumbered traffic deaths. So it became a leading cause of death of, premature death of young people in 2010 at 31 states, and now it's the leading cause nationwide. If we look at this is a 2010 overdose deaths per 100,000 residents. Rhode Island's up here. Vermont had the governor's State of the State address focused on one topic this year in January. That's very unusual for a governor to say, this is our most important thing of our state needs to focus on, and it was overdose deaths. And it's appropriate because it's a leading cause of deaths. But this is Vermont down here. The rest of New England is somewhere around here. New York, drug capital of the world, it's there. Massachusetts is a little bit worse. Rhode Island's even worse. So this is 13.5 per 100,000. However, this first quarter, 2014, we've had 75 unintentional overdose. So that's 300 deaths. That puts us at 28.6 per 100,000 population, which is worse than West Virginia as of 2010. So we have a big problem here. We're a little worse in Rhode Island, but this is a nationwide problem. And it correlates with prescription, the deaths, the sales, and of course more people with addiction, more people getting into treatment. So we have an epidemic of overdose. It's extremely expensive. $37,000 per overdose event has been estimated. And in addition to those people that are dying, there are quite a number of people overdosing, not dying, but incurring medical costs. And this is just Rhode Island data, over 2,000 hospitalizations, over 4,000 emergency room visits. The population of Rhode Island is only 1 million, so more than a third of people fill the prescription for a controlled substance. And some of them, a small percentage of them are really doctor shopping, but 5 different prescribers, 5 different pharmacies. And one of the strategies to try and rein this in is what they call the prescription monitoring program. It's a big database of all of the prescriptions in the state and who the prescribers are. Many states have moved in that direction. This was a push really coming from law enforcement, not so much from public health, but there's public health opportunities with that. And clearly we can identify some of the prescribers and some of the individuals and try and rein that in. So for every person that overdoses and dies, there's 15 other people that are in treatment, ER visits, a lot of people who are dependent, and then there's a lot of people that are using. But this is a lot of money that we're spending on this problem. Okay, so now what's this all about? Why are people taking these opiates? What's the big idea? This is the opiate, natural substance, morphine and codeine, and then semi-synthetic and fully synthetic. But they all pretty much do a very similar thing, and I often talk to people about it's such a consistent disease. It's kind of like, I'll talk to somebody and I'll ask them a question about and I've never met them before, and I know the answer because I've heard it 100 times before. It's a very consistent disease. It's kind of like looking at a room full of Down syndrome kids. It doesn't matter if they're black or white or Asian or whatever. There's something very similar about all of them. Different variations on a theme, and it's a very consistent disease. So why so heroin is pleasurable, and heroin, I say heroin, it has some properties that make it different than other opiates. It's lipid soluble, it crosses blood-brain barrier quickly, gives you a rush, and gets to the brain more efficiently than others, and it gets metabolized to morphine. But so somebody gets an opiate, and 20 years ago when I went to Rhode Island, I went there to really work on HIV. We had a terrible HIV epidemic. It was predominantly injection drug use. We were one of only 4 states with more than half of the AIDS cases related to injection drug use. You talk to a drug user there, and I did this. I did HIV testing, and as part of the testing I would go through, do pre-test counseling, go over their risk factors, and patients would tell me over and over again, oh my God, I can't believe I did this, but I took that syringe right out of that guy's arm, and I said, well, why did you do that? Well, it turns out that Rhode Island had outlawed syringes. 5-year felony for possession of a single syringe. I had a patient who had a dozen syringes in his pocket, no drugs, got arrested. The judge said, I could send you to jail for 60 years. No drugs. I don't think you got the full 60. But actually it was vigorously enforced. And as a result, people would go someplace to get their drug. They would take a syringe there. They would shoot up their drug. They would leave the syringe there, and somebody else would come along and do the same thing. You couldn't have designed a better law to encourage transmission of bloodborne pathogens. So, through my medical training, I met people who were addicted, but it wasn't really until that clinic that I started talking to people and understanding what is this addiction about? Why are you using this stuff? And at that time, the typical person who was using, it started in their 20s, late 20s, early 30s, and we live in a culture of addiction. We teach our kids to get addicted to nicotine early, and then alcohol, and then maybe marijuana and other substances, and then move on, graduate to cocaine and maybe amphetamines, and then opiates. Those kind of that's the ones that inject. Those are like the PhDs of drug users. But so nowadays, the typical opiate user starts in their teenage years, in their early 20s. And they're somebody who maybe had an orthopedic or injury or a sports injury, hurt their ankle. They go to see the doctor gives them a script for a lot of opiates. It's not like, okay, here's a day's worth, for your sprained ankle. Here's a month's worth. It's like you just gave someone a month's, 60 Vicodins for a sprained ankle that's going to be better, and probably just needs some ice. But that's where we're at today. And so then somebody starts taking it, and they take it, and they kind of like the feeling. It helps the sore ankle, but there's something else going on there. And then they take it again, and then they find that after a while they're taking it more and more. And so if we think about this sort of early use, it's also called chipping in the vernacular, or use it on the weekend. They're right here, they feel normal. They take it, and they have a pleasurable feeling. And as the drug wears off, it comes down, and then they take it again, and so forth. And then they start doing this regularly. Now, it doesn't take long for 2 things to develop if you use it consistently. in the body. Any idea what those could be? First, you develop tolerance. So what does that mean? It doesn't work as well. You need more. So you need a higher dose to achieve the same effect. So if you take the first dose, you get, whoa, way up here. But then over time, you take the same dose, and you don't quite get as high. So the natural history of the use of opiates is to take more and more and more to get the same effect. That can occur fairly quickly, days to weeks. The other thing very important about tolerance is you can lose it very quickly, days to weeks. And, alcohol gives you tolerance as well. Everybody heard of somebody that can drink everybody under the table. But there's usually a sort of a plateau effect. Not so much for opiates. People can go very high on opiates. So what's the second physiologic thing that happens? You develop tolerance. Dependence, which is withdrawal. So the withdrawal phenomena. And I would encourage any of you who haven't to talk to somebody who's been through withdrawal to tell, what is it like? But they will tell you that when they first start withdrawal, now heroin, a lot of people transition to, is a TID drug. You have to take it 3 times a day. So if you're not taking it 3 times a day and you're in sort of this phase where you have tolerance and dependence, you go into withdrawal. So instead of here where you're high and then you're getting normal, here you're normal and then you don't take anything and then you go into withdrawal. So you have to take it to get up here. And patients say that all the time. Doc, I don't even get high anymore. I just want to feel normal. I want to get off of E. E like the gas, your gas tank. You're empty. You're out of gas. And you need this to feel normal, to just function. And so that transition happens. And then people say, oh, my God, what's going on here? So you're taking heroin 3 times a day. You only get it twice. You stop taking it. First your nose starts running. You start aching. You're feeling aching all over. Your belly's aching. And then, as time goes by, you're feeling worse. Then you're feeling nauseous. You got goosebumps. And you're feeling like, you can't get out of your skin. And then you're really nauseous. And then you start throwing up. And then you start having the runs. Patient said, Doc, at that point, I go in the bathroom, I don't know which end to point towards the toilet because I'm blowing out both ends. And then there's nothing. You're just dry retching. There's nothing left. And you see a patient like this, and they are curled in the fetal position. They're just rocking, and they're just saying, make it go away, make it stop. They're miserable. Imagine the worst flu you ever had, and it's got to be 10 times worse than that. And yet they know they can get one little pill, one little fingernail full of powder, snort it, shoot it, and it just melts away. Now, if they're using heroin and they go through that withdrawal, after about day and a half, 2 days, 3 days, it starts to break. And then, that's the withdrawal. So then you start to feel normal. And then they're cured. Well, they're not cured at all. But they're out of that withdrawal phase. Okay, questions on that? So we have some medications. Naloxone is a complete antagonist. It blocks the effects. So it has a high affinity for the receptor. It'll block an opiate and knock it off the receptor, and you will not have any of the effects of the opiates. Agonists look like this. You give a higher dose, you get a higher effect. So, and then buprenorphine is a mixed agonist-antagonist. It follows the same curve early on. So that means if you're down here and you take an opiate, an agonist like morphine, like oxycodone, like Vicodin, like Percocet, you'll get an effect. So you can get some pain relief. And buprenorphine the same. But then it'll level out. So you take a higher dose, you're not going to get up here.
So by opioid effect, you mean getting high?
Well, so it could be high. It could be that pleasurable feeling. It could be the pain relief. It could be the withdrawal, the alleviation of the symptoms of withdrawal.
I mean, do you get high on methadone? Okay.
Yeah, so methadone, people do get high on methadone, and methadone has a long half-life. So you can give it once daily or even less frequently. And what you see when you give someone methadone and it's adjusted appropriately, sort of imagine that previous slide, sort of in the middle part where you're feeling normal. If you're taking methadone, it's kind of going like this, and you're staying in that normal range. You're not going down here in withdrawal. You're not going up there and get high. If you take a high dose, you can get up there high. So here is sort of pain relief. Here is withdrawal relief. Here is that getting high, that euphoria. And here you start to become sedated. And some people, between here and here, people say, oh, that's getting a nod. Like it's like they have this pleasurable euphoria, they're just kind of passing out. But then they start, not only is their brain kind of going to sleep, but their breathing is kind of going to sleep. And then up here you stop breathing. Question?
So the buprenorphine is the Suboxone, right?
Correct. That's a component.
Like so that's why some people say when they take Suboxone they can get a little high, but a lot of people who
Right.
are heavy users say there's no high value for them because it's putting
Right.
them below where they would normally be.
So,
For a non-user, it would put them above.
yeah, so when you say user or non-user, it's really about whether they have tolerance or not.
Sorry,
So if
heavy
they have tolerance, if they're up here,
it's going to bring them down.
you can precipitate acute withdrawal. They will be just as miserable as if they just stopped. In fact, you'll precipitate it much quicker. Likewise, if you give them naloxone, you can precipitate withdrawal. They'll go from feeling great to throwing up all over your ambulance or office, wherever you're at, and pretty miserable, and unhappy, and can get combative, and it's respiratory depression. So some emergency EMTs in the field will get someone, there's an overdose. Really the problem is the respiratory depression. So if they just breathe for them, then they'll be okay. So they get them in the ambulance, they're breathing for them, and then they get close to the emergency room, then they give them the Narcan, and then they hand them over. Because if they do that too soon, they wake up, they feel miserable, they're pissed off. You just blew all their dope. They spend all that money on the dope. All right. So, adjusted properly, this is really life-saving. It's wonderful. When you see what somebody does. Now, I just want to digress a little bit about what addiction does to people in addition to these physiologic things. So you find out that you've been using opiates for a while, you find this pleasurable feeling, and then you figure out that, if I stop it, I'm in trouble. So then you got to take some more. So then you go back to the doctor and say, yeah, well, not only my knees hurting, my back is really hurting, and I need some more because I'm just miserable. And this really helps, doc, really helps. And people get really good at, kind of scamming their doctors. But eventually the doctor wises up and says, that's it. You just had a sprained ankle. You shouldn't be on 3 months of higher and higher doses. So they get shut off. And then they have a grandma who has some in the cabinet, and then they use that, last for a while, and then they have a friend who can sell it to them for something, and then they start paying, and then they find out it's pretty expensive, but they're paying for it. And $50, $100 a day is not an unusual amount to spend for an opiate addiction. So if I looked in my wallet right now, I might or might not have $50 or $100. Tomorrow I'd be very unlikely, and the next day I'd be hitting the cash machine. And by about the middle of next week, my wife would say, "What the hell is going on?" And yet people do it. I mean, you meet someone who's been using, shooting up opiates for 10 years. So, my God, how did you manage to do that? So how do people do it? They usually do one of three things. They either steal things, they sell their body for sex, or they get involved in the drug trade. And getting involved in the drug trade is not, sneaking over to the schoolyard and addicting little kids. But it is, it does, it's more like, hey, if you take this dope over to that funny-looking guy in the corner there, you can take a little, you can have some of it. And so you do that, and you do that for a while, and then, of course, you get caught, and then you got all this dope, and so you're a big dealer, so we're going to send you into the criminal justice system. Okay. Questions?
Do people ever transition from prescription opiate use? I'm sure that ever they do, but is it typical to see someone transition from prescription opiate use to injection drug use because of the cost?
Yeah, exactly. It's she's a plant in the audience. So what people do is they pay all this money for these pills. OxyContin is $1 a milligram. So that can be quite expensive. And then somebody says, hey, heroin's a lot cheaper. And you can probably get high still on the heroin. And they say, really? Okay, I'll try that. And then they start snorting some heroin because nobody wants to inject drugs because then you'll be one of them, one of those people. It's like crossing a line. And yet, so they start snorting. And what happens? Their tolerance goes up. So they're snorting less, but then their tolerance, so then they're snorting more. And then they're spending just as much as they used to spend on pills. And then somebody says, hey, if you shoot it up, first of all, you'll get high because you'll get a better rush. And second of all, you'll use less and you'll be fine. And so they do that. And in fact, it's true. They shoot up, they get high, they use less. And then another week or two goes by, and then by that point they're shooting up that much, and then they're stuck because there's no turning back. And that sort of middle area where I said methadone keeps you here. Heroin injection is going to send you up to high and then send you right back down as it wears off. And so when you're doing this 3 times a day, most of your time is spent either up here when you're stoned or down here when you're in withdrawal, and very little time normal. Whereas, in methadone or even buprenorphine or adjusted, most of your time is you're feeling normal. All right. So, in 1800s, we had the Civil War. 620,000 people died. 2/3 of those from medical illness. But 400,000 returned home with the soldier's disease. They were addicted to morphine and opium. And so, that the doctors had to deal with it. And they found out that if you give somebody who's addicted to opiates, they actually go from being desperate in withdrawal to actually functioning and doing well. And so opiates, in the early 20th century, opiates were freely prescribed. Heroin was a Bayer product. Doctors used them. There's Bayer Pharmaceutical making heroin. Thank you. And then we got some regulation going. So the Harrison Act of 1914 said, oh, this is bad. These people are using there was not a sense of addiction. This is like, these are depraved people and they need to be taken off of this stuff. So they established some taxes, and they had licensed doctors, but the doctors that were found in violation could be arrested or have their licenses revoked. So that's good. 25,000 physicians in 1914 or shortly thereafter were found in violation, and 10% of those were in prison. So, you kind of had this, opiates were being used, and this is like a pendulum swing, and then talk about swinging a pendulum back in a hurry. All you need to do is arrest a bunch of doctors for doing what they thought was in their best interest of their patients. And that pendulum swung all the way. That's it. No more opiate use. Party's over. There's the special stamp. And that stayed over there until the 60s. Of course, people were still getting addicted to opiates, and of course they weren't getting any prescription opiates or any treatment. But in Dole and Neiswander and others in the 60s really found out that if you give people methadone, their life turns around 180 degrees. They start functioning and they stop dying. This is a deadly disease. So the data was so compelling, so stark that the government had to, and they begrudgingly approved methadone, but only in the tightly controlled, well circumscribed, only certain programs. And so that was, 50 years ago. And then a few years after that, or a few decades, there was a realization that, hey, we're not doing a good job with cancer pain, particularly cancer pain. People are dying at the end of their life, and the doctors are like, oh, I can't give them opiates. They might become addicted, or they might, it's like, what are you doing? And we were way off base. So the WHO and many others said, we should try, non-opioid. We should be treating. And then the WHO and the American Pain Society, but somehow there was a transition from the 80s to 90s that this is not just about cancer pain, this is also chronic pain. So this pendulum starts to swing back. And in fact, JCAHO, 2001, has pain standards. So if you have, they call it the fifth vital sign, the blood pressure and the pulse and the respiration and so forth, and then pain. So if somebody has pain, how are you going to know they have pain? You can't stick a pain thermometer in them. You have to ask them. So if you're not asking them, and JCAHO says something and everybody lines up because that's threatening your livelihood. So, when JCAHO gets in the, so all of a sudden you're measured on, did you ask about pain? So now, you go into any emergency room, oh, how's your pain today? Is it on a 1 to 10? What's your pain? It's like, what do you mean? I came in for, but the pain is, a big thing, a big focus on what the doc, and then how you're doing with the treating pain. You're measured on customer satisfaction. So if you don't take care of someone's pain, well, you get, dinged for that. If you take good care of someone's pain, you get a star or a check mark. If you take really good pain, you get a star. So doctors were encouraged to address pain. So what do we have to address pain? We have opiates. So doctors were kind of encouraged. Now, initially, WHO guidelines and others said, we got to treat pain with all kinds of other things. Like you can't just give opiates. But insurance companies are not going to fund all these other things. There's a lot of, for chronic pain, strong psychological impact. And, if you don't have a good night's sleep, well, any pain you have is a lot worse. So if you have a sleep problem, if you have depression, if you have other psychological issues, if you have pain and you move and it hurts, you don't want to move. So then people just lose function and actually that's the worst thing you can do for pain, chronic pain, is to not move. But, so you need physical therapy, you need to get out there and move, and you can, there's a lot of things we can do for pain other than give it opiates, but the insurance isn't going to cover it. We're not going to have a psychiatrist, psychologist, physical therapist all sitting around a room talking about it, one patient. They're here, you're in the emergency room, you just write a prescription, you give it to them. So that is, the pendulum is swinging back full force because it's so much easier just to write that script, give it to the patient, done, next, in a busy emergency room, busy practice. There is this, and then of course people develop tolerance because they're taking opiates regularly, so they need more, and then pain's not helping. And there's I should mention this opioid-induced hyperalgesia. Ironically, people's pain gets worse when you go up too high. But there's, we can do a better job managing pain, and there's a number of resources out there to do that. But now so this pendulum is swinging along, and then along comes the big pharma. They had a role in this, and I guess I'm picking on Purdue Pharma, but probably with good reason. So interestingly, but they're not alone. So Purdue had MS-Contin, a sustained release morphine. You can take it twice a day. And interestingly enough, in the mid-90s, the patent was expiring, so they're going to, try it. So then they have this OxyContin. It's oxycodone, a commonly used, widely available medication, opiate. You have to take it 4 times a day. They come up with this where you can take it twice a day. FDA looked at it and said, well, it's really no different except you take it twice a day. It's not better, it's not worse. So they approved it. Now Purdue released it in 96, they had $48 million in sales. Sounds like a lot of money. In 4 years, they up to 1.1 billion. And in 2001, 2002, I think they had a total of $3 billion. I mean, this is much more than a blockbuster. This is like off the charts. And how do they do that? Because it's really no different than the other generic that was available, other than the timing. It's a delayed release, and it turns out if you crush it or you can snort it and inject it, and you can get a much quicker release. They spent in 2001 alone $200 million marketing and promoting this, and by 2000, in the late 90s, there were reports of diversion and abuse. By 2004, it was the leading prescription drug of abuse. So high rates of diversion, I think I mentioned that. So they did this, they had aggressive marketing. So they can buy data sets of physicians' prescribing practices. So they know which physician is prescribing how much of whatever medication. And they took that data and they said, here's somebody in West Virginia, he seems to be prescribing a lot. Let's target him, because maybe he could prescribe even more. And then they gave him fishing hats, stuffed toys. The use of such branded promotional items for a Schedule II opioid is unprecedented. I mean, they took the standard stuff that we used to sell blood pressure medicines and they applied it to opiates. They gave bonuses to their sales, so their salespeople, they had a base salary of $55,000. They gave an average $71,000 bonus on top of that, a range of $15,000 to $240,000. So if you, and the bonus is straightforward. It's not on how good you look, but you have to be good looking and you have to have whatever kind of appeal to whatever the doctors want. But it's very straightforward. You get the doctors to sell more of this drug, whatever way you can, you're going to get a big bonus. So they blurred the marketing and the education. They took doctors to these junkets, all expense-paid conferences in very swank places, and wined and dined them and said, oh yeah, by the way, you're going to be on our speakers bureau, and then anytime you give a lecture, we're going to give you thousands of dollars to go talk to your peers and your friends. And they're going to do educational materials, textbooks, and they kind of promoted this idea that, well, if you treat pain appropriately with an opiate, and I heard this through medical school, later on, but if you give appropriate pain, if somebody, that they're not going to get addicted. They just won't. That was the risk of diversion and addiction, unless you give it to the wrong patient, you don't even worry about it. It's not going to happen. That was the message. That was, that kind of, and the way doctors learn things is, they learn it from your peers and whatever. So they were extremely effective. And then the Kentucky Attorney General filed a case against them, actively misleading providers, consumers, and government officials. And guess what? They were guilty. 3 executives, including the president and the top lawyer, pled guilty to misbranding, $630 million in fines. They didn't have to pay for health care and rehab costs because it was argued the patients were not directly the victims of misrepresenting the OxyContin. This, the poor doctors and the government. So this is where OxyContin came in, and this is you can look at overdose mortality. You can look at all these things. So this is an epidemic of opioid addiction. Now, there's a strong genetic component to opiate addiction. Not everybody who gets exposed to opiates is going to get into trouble. If you have 100 young people and you expose 5 of them to opiates to the point where they get into trouble, get into tolerance and withdrawal, a couple of them are going to get into trouble. If you expose 50 of them, then a couple dozen are going to get into trouble. And that's exactly what we've done. We have flooded the market with opiates, and this is a whole generation that we are in a big trouble with. And and so the overdose deaths are just a reflection of that epidemic. And really just these are the canaries in the coal mine. And so it starts usually with prescription opiates, can start with heroin. Then and any time during this progression from just starting to, getting, completely addicted, somebody can overdose. Now, I mentioned that tolerance drops off quickly if you stop using. And so if you resume using at the same level that you were using before, and it can be just days to weeks, you're at risk for overdose. Yeah?
This is very helpful, very clear presentation, so thank you. But this slide, where you start with opioid misuse and then heroin comes in, if you go back to your very first slides that had the Rhode Island data on it,
Yeah.
the deaths were attributed almost entirely to
A lot of prescription opiates, yeah.
So are you saying that heroin really is not playing a significant role in this uptick in opioid deaths?
So there was a fair amount of overlap between that. So there's some overlap. So maybe a third or a third to a half have both, either only heroin or heroin plus prescription. I mentioned the prescription monitoring program. The tonnage of opiates we are pouring onto the market is causing the problem, and we are starting to realize that. We're starting to pull back prescription monitoring, and we're going to pull back. We're going to, clamp down on the doctors. We're going to change their practices. But I imagine a water balloon half filled with water. As we clamp down on these pharmaceutical supply, the heroin supply is going to balloon out, and there's a lot of data to show that's already happening. So somebody who's addicted to opiates, the pathways in their brain have changed, and I tell people, you now have opiate addiction. You are at risk probably for the rest of your life. Every day you wake up for using, for relapsing. Doesn't mean you have to. Doesn't mean you're going to, but you have that risk behavior, that risk factor, and so. This is a problem for the rest of your life. Sorry, question.
So, in my experience working with injection drug users or heroin usually is the thing that we're sort of seeing causing the overdoses.
Yeah.
But would you argue, but it's clear that the prescription drugs are, in these slides are a big problem. So would you argue that prescription drugs sort of escape some of the culpability because of that sort of pathway of use? Like you said, it sort of starts with prescription drugs and then we sort of end up at injection drug heroin use. So it gets blamed on heroin when really the origin is usually something much more.
It's the same disease.
Absolutely.
So that's the issue.
Sort of the
And
blame
people,
factor.
yeah. So people transition. I mean, there's plenty of blame to go around. But people do transition depending on the economics and the supply
But
change.
Culturally, sort of we have a very different attitude towards heroin
Right.
than prescription
Right.
drug addiction.
Right.
So it's the same addiction,
Now-
but we feel differently about the name of it.
Right. So, I mean, I think that's all true. But what we have now is a generation that's addicted, and the only way to keep that balloon, as we clamp down on the pharmaceuticals, the only way to keep that heroin balloon is to get people into treatment. Yeah.
I think it's very important that we understand what we mean by the word clamp down.
Yeah.
Because there are a lot of people that have chronic pain for which opioids are an appropriate treatment. And so I think it's not so much the word clamp down, because otherwise we won't be able to get pain medicine to people that actually require it, need it, and are taking it in a stable way, in a safe way. I think it's more about physician education and making sure that we appropriately screen people for when we're deciding to give them opiates. People that have family histories, people that have a history of substance abuse in the past, people that have all sorts of risk factors for opiate addiction. Those people probably should not be getting opioids, even if they have a pain diagnosis that's appropriate, or if they do get pain medications, they should be watched in a very, very special way. Physicians in general haven't been trained very well for use of opioids and treating chronic pain, and so they've historically given it out indiscriminately without the correct monitoring or screening. If it's done correctly, we can probably thread the needle between both of these bullseyes. If we just say no more prescription pain medicines, then
Yeah.
a whole other part of the population is going to suffer.
Right. I agree with most of that. I would just point out that this is a medical intervention, and every intervention has risks and benefits, and it should be carefully weighed, and doctors need to be trained and educated. And the Purdue, they didn't target the pain specialists and the and the addiction specialists. They targeted family docs that didn't have a lot of training, that were just didn't have all this sophistication. But I would also, I would say that there are no studies of the long-term use of opiates to treat chronic pain. We don't, we say it works. The patients tell us it works. It probably does work, but we don't have any good data on that. So, yeah.
Before you go on,
Yeah.
I just wanted to interject, because you've got about 10 minutes, and some people may have come to hear about incarceration.
Incarceration.
And HIV, and I wonder how it fits in, and if
Yeah.
you could save some time for that, it would be really great.
Okay. Do you want to?
Go.
Okay. So I'll go.
Thanks
I'll.
about HIV.
No,
Oh.
it's a lot of training.
This is Alex Wally's data on the great opiate Narcan program in the state here. And a lot of the participants had been incarcerated. And of course, as I mentioned, if you stop someone's opiate use or reduce it dramatically, which is what happens during incarceration, and then you let them out and they reuse again. So 129 times increased risk of overdose in the first 2 weeks after release from incarceration. So we have, in addition to our opiate epidemic, we happen to have an incarceration epidemic. This is 1982. Ronald Reagan was president, and we were asking, what are prisons for? Why are we locking up so many people? This is 1982. So right when we were asking that question, we went incarceration crazy. We had a bit of like an arms race with the Soviet Union, but after it was an incarceration race, and we left them in the dust. We are number one, baby. No longer the land of the free. 5% of the world's population, 25% of the world's prisoners. Predominantly African American or people of color, poor people. And, along with these rates of incarceration, we're spending a lot of money at the federal, state, and local level, local counties and jails. Half the population has drug abuse or dependence, more alcohol, and majority have mental illness. So why did we start locking people up? Because we made, during Prohibition, we made distribution of alcohol illegal, and it didn't work. But we didn't make consumption of alcohol illegal. Consumption of drugs is illegal. You have drugs for your own personal consumption, you're going to jail. So that's very different. We've also deinstitutionalized, which was wonderful, liberating for so many people, and good for them, good for society to have diversity of people in the world, but it wasn't accompanied by enough of a safety net, and a lot of people fall through the cracks. And when they do something crazy, they get arrested, they come back to the judge, and when everything, when all you have is a hammer, everything starts looking like a nail. They're like, okay, I can let him go out, and he can do more crazy things, or I can lock him up. That's the only choice they have. So that's really what drove and is driving this epidemic of incarceration. And it's just, it's wrong. This epidemic is happening on our watch, and it is wrong. It's a terrible waste of resources. It is, now don't get me wrong, some people it's life-saving to be arrested. I hear that a lot. Doc, if I hadn't got arrested when I did, I'd be dead, and they're not kidding. But what we're doing is fundamentally wrong, and we can do a lot better with a lot less resources. Now, this population that ends up incarcerated has a heavy burden of disease. And 1976, the Supreme Court found that not providing community standard care to somebody who's incarcerated is cruel and unusual punishment, and therefore prohibited by the Constitution. So this spawned a whole series of lawsuits and threatened lawsuits that has dramatically improved the care that prisoners get, which is a good thing. So I think of incarceration, coming from the medical public health perspective, as it's an opportunity to make a diagnosis, to treat, prevent. Doesn't mean we shouldn't be trying to stop people from getting incarcerated at the rates they're getting incarcerated. Now, don't get me wrong, there's plenty of people that do need to be incarcerated for their safety and for the safety of the society, but not this many people. And so when we look at who's behind bars, we have about 2.2 million people behind bars. And that graph I showed you went up, 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 and then the last couple of years it kind of went down to here. And people say, oh, well, incarceration rate is on the decline. We're problem solved. The rest of the world is down here. So 750,000 people released from state and federal prisons. There's about 1.5 million in state and federal prisons, about 750,000 in jails, county jails. And so about half of the turnover from prisons each year. But jails is almost 9 million. So overall, we got about 10 million people. So we got 2+ million people behind bars today, but we have this sort of tide, it's because I'm from Rhode Island, the ocean state, of 10 million people going in and out every year. So as they're going out, I already told you overdose rates is high. They die from other causes as well. They re-engage in activities that put them at risk for acquiring and transmitting diseases. They relapse to addiction and they get reincarcerated. So when they get out, there's not a lot of options, but this door is always open. When I first started providing care, and Rhode Island's so small, we have the largest HIV clinic at the Miriam Hospital. 85% of the people in care are there. And we have, a single combined prison and jail. So I can go down there, take care of my patients, and then come see them back at the hospital. I say, okay, you're doing good now, you're on your medicines, I'll see you on Tuesday at the clinic. And they didn't show. Why didn't they show? What's going on? Don't you know this? And when I started this, of course, we didn't have effective antiviral therapy. So this is it was a deadly disease, and it was terrifying. It was a whole different era. And yet people didn't come for care. Well, what's going on here? And then I started talking to them, and I said, well, Doc, listen. When I'm here, it's no fun being locked up. And the transition from being outside to being in is no fun, particularly if you're on opiates and you have to go through withdrawal. But that pales in comparison to the transition from being inside to being outside. Because when you're in, even though it's boring and it's regimented, you know where you're going to sleep, you know where your next meal's coming from, and pretty much you got a kind of stable existence. When you get out, where am I going to eat? Where am I going to sleep? How am I going to deal with the voices in my head? How am I going to keep from getting beaten up? How am I going to keep my kids from getting beaten up? Or feed them, or take care of them. What about all these other relationships that are all of this comes down on you and so, yeah, Doc, you're telling me about something that's not going to kill me for 6 to 12 months? I've got to live today. In that context, there's not surprising they don't show up. They don't show up right away. In addition to the infectious diseases, there are higher rates of many diseases in the incarcerated population. Now we think about this tide going in and out. If we look at, this is from 97 data, it's changed slightly, but 20 to 26% of all the AIDS, everybody with HIV/AIDS in the country pass through a correctional facility each year. That's come down a bit. It's maybe 15%. But these are the people that are less likely to know they have HIV, that are more likely to have hepatitis C, comorbid conditions, mental illness, addiction, and other problems. And now that we are realizing that we actually can see the light at the end of the tunnel, that we can treat our way out of this AIDS epidemic, that if we treat somebody and control their virus, that they are essentially no longer contagious to others. That's very exciting, but you've got to get them into care. And these are the most challenging people to get into care. Similarly, a third of hepatitis C. Hepatitis C is another very exciting time because our treatment is finally effective, extremely effective, and short course and well tolerated. Unfortunately, very expensive. And I'm just going to show this. So this is a study done with Texas data. They looked at over 2,000 prisoners with HIV on medicines, and they have a ADAP, AIDS Drug Assistance Program, which was actually relatively user-friendly. You pretty much just had to make a phone call, and they tell you which pharmacy to go and pick up your meds. And they gave everyone 10 days' worth of medicines upon release. So these are prisoners. These aren't people coming in and out of jail that have only been there a day or two. These been in Texas, they've been there for a while. So they had time to plan for their release. 5% of them went to the pharmacy and got their meds filled within 10 days. Only a third within a couple of months. So these are people that are on treatment, that are doing well, best scenario, and then they walk out the door and they just fall into that abyss. So we're doing pretty good on the inside treating people with HIV. And I say that because mortality rates, when antivirals, effective antiviral therapy came out, mortality rate dropped dramatically in the community because the meds were so effective. And there was a parallel drop in mortality behind bars. So I know that we're doing pretty good on the inside, pretty good on the outside. But in this transition point, we got a lot of work to do. We set up a collaboration on HIV and corrections. And I think I'll just stop there. But really, we've got to try and stop this epidemic of incarceration. Think of better ways, alternatives to incarceration, focus on reentry, and at the same time capitalize on these tremendous public health opportunities. Thank you much. So I don't know if we have time for
Yeah, I think
questions.
we realize that some people may need to leave and do whatever they need to do, but we will take some questions, if that's okay with you,
Yeah,
Judy.
yeah. Yeah.
So this is very interesting and very helpful, but you keep coming back to doctors as the problem. And that they're either manipulated by the drug companies or they're manipulated by their patients.
Yeah.
Right? So doctors come across pretty much as suckers who have the prescription payments.
Yeah.
And so the people want to sell drugs, focus on them, and the people want to get drugs, focus on them.
Yeah.
So what do you do about that? I mean, it seems to me that that is the point at which one could really affect health.
Yeah, so we don't do education about addiction in medical school. We don't, we're not good about that. So we need to do that. We don't have good education about pain control and all these things that were mentioned. We definitely need to do a much better job. I've tried to get doctors to prescribe buprenorphine, Suboxone, and when you do that, it's just wonderful because you take somebody who's, especially when you see what their life was like before, and then you see them come back to humanity, come back to, opiate addiction turns people into monsters.
That's once you get it, but it
So-
seems like you discuss doctors as being really a focused cause as opposed to treating.
Right. Well, they are. They're both. We need to swing that pendulum back, and we need to deal with. So, well, there's a number of ways, but certainly starting the young kids, as they're coming through the system, educate them that what, when somebody comes in with a sprained ankle, they need ice, they need Motrin, maybe they need a couple of Vicodins. They don't need 30 Vicodins. They don't need 60 Vicodins. But that is the culture. So we have to change the culture. We have to get the word out that you're. So we do that one step at a time, and we do that by bringing attention to the overdose, because by you writing, 90 pain pills, a month's worth of pain pills for somebody, you're contributing to that. So in Rhode Island, we're trying. We're with this prescription monitoring program. I've encouraged the health department to go and find out every one of those people that died, who wrote them opiates. and just do a friendly visit to say, you know what, your patient died of an overdose. We're not saying that you did anything terribly wrong, but you should reevaluate, and here's a bunch of resources about appropriate management of pain and about appropriate. Now, in trying to encourage people to prescribe Suboxone, basically if you have an FDA license, you take 8 hours of training, which you can do online in about 4.5, that you can get a Suboxone, a buprenorphine license. We've tried to encourage doctors to do that. And part of it is when you find somebody that has been scamming you, they've been taking these, and doctors take such umbrage. They're like, how dare he lied to me? That's it, you're out of here. And it's not that. It's what the response should be. Your tox screen shows this. You've been using this, and so this makes me think that we have a new diagnosis here, opiate addiction, and we have treatment for that, and we can try this and we can try that. I'm still your doctor. I'm still going to have this doctor-patient relationship. So that's one way. Yeah.
This is the question I had before, because I think it's like we toss around we can train the doctors easily. I think
Yeah.
that's a problem of kind of unfathomable breadth and depth. I think most of us know that you shouldn't give opiates prescribed, right? And also most doctors want to help the patients who have legitimate pain and understand there is pain.
Yeah.
And so the hard thing is how to manage opiates. It's not how to find these opiates for sprained ankles. I mean, I'm sure that's a problem.
Yeah,
too.
yeah.
That's relatively easy.
Yeah.
The harder thing is my folks who I see all the time. And I'll tell you, I don't know what percentage of doctors are official pain specialists,
Right.
but that's the percentage of people who have training in opiate use. No
Right.
one knows how to use
Right.
opiates. No one trains you ever, even if you're an HIV and Hep C provider. Like I am.
Absolutely. Yeah.
And so it's as if we just sort of are turning people loose to practice medicine with absolutely no training.
Yep.
So it goes deep. I don't know how you.
And if your choice
You
is
just deregulate
if your choice is to rob a bank, rob a drugstore, sell your body for sex, risk getting incarcerated, or convincing your doctor that I got this terrible pain, that's what people do, and it works. It gets them by. It gets them through the day.